Hi, I'm Brad Power, and this is the Cancer Patient Lab. Today, we're honored to have Dr. Ahmed Elsakka with us. He's going to be talking to us about his work in um, how cancer can grow and get fed and the metabolic approach. He's a colleague of Dr. Naisha Winters, who's been on our session before and who recommended him to us. There are three housekeeping things that we typically do at the front. The first is that this is for informational purposes only. This is not medical advice. We try to arm patients with and caregivers with information they can take to their medical team. The second is that everything will be made public. And so if you're concerned about your image or anything you might say being made public, then hide your image, change your name, and don't say anything. And then finally, we are a patient-led, volunteer-led nonprofit, and we welcome donations, which you can do through our website at cancerpatientlab.org, and there's a donate button. So with that, I'll turn it over to Dr. Elsakka and to Roger.
Thank you, Brad. First of all, I need to express how lucky I am to be with amazing people like you guys. I'm really appreciate that, and thank you for giving me the opportunity to be a part of this wonderful event. So allow me to share my screen.
You're not able to share? Hold on.
Able right now. Thank you. I'm sorry, I'm very bad with technology, so excuse me for that. Okay, so are you seeing my screen right now?
Yes, we are.
Good, great. So today, our topic will be with the new horizon in metabolic management of cancer, which means I'm not introducing anything new for you. I think most of you knowing this information before. However, how to implant this information by a simple and effective way, how to translate this medical information from the bench side to the bedside is what it matters. Because science without application is not a science for me. So today I was focusing on exposing my idea about cancer metabolism and how we can make this happen in clinical setting. First, let me differentiate between the metabolic management of cancer and the standard of care. The metabolic management of cancer, actually, we target the cancer metabolic pathway. We don't targeting the cell directly. We target the metabolic pathway that enable the cancer cell to survive. Unlike the traditional therapy, which is the chemotherapy and radiotherapy, which is focused on direct cell death, however, the metabolic management aims to starve or destabilize the cancer cell by changing the energy source, the redox balance, the signal transductions, and even epigenetic modifications. And we need to know that this approach could potentially work alongside. So both standard of care and metabolic management work perfect together. And we see the best result when we're combining the standard of care with the metabolic management. It's not alternative, it's complementary to each other. Today, as you know, we will talk about the ferroptosis, application of sound and light in cancer, methionine restrictions, and nanotechnology in drug delivery system. Let's start with the ferroptosis. Ferroptosis is a new term that being scientifically described in 2009. Before that, there is no word of ferroptosis over the research institutes. So ferroptosis is intracellular iron-dependent form of the cell death. It's completely different than apoptosis or necrosis, because actually it depends on two mechanisms, the iron dependency and the lipid peroxidations. So this cancer cell death mechanism to occur, we need the cancer cell that have a very high iron or free label iron. And also this iron can be highly oxidized to oxidize the lipid, coding lipid peroxidations. So ferroptosis actually is a very good therapeutic opportunity for certain cancer types like liver and pancreatic cancers, especially the KRAS mutated cancer. This is the most cancers that showing a very response to the ferroptosis protocol. Some chemotherapy itself can trigger the ferroptosis, like Cysteine that being used in hepatocellular carcinoma. Some phytochemicals that coming from the nutraceutical, like artemisia or piperlongumine or wizaferin A, a lot of them, but this is an example. Some off-label drugs like sulfasalazine, all of them can trigger the cancer cell ferroptotic cell death. So actually, ferroptosis is a very new hope for treatment cancer, which usually resistant to the chemotherapy or traditional radiotherapy. And to understand what the role of iron inside the cancer cell, let's introduce you to hepcidin. Hepcidin is the iron-regulated peptide hormone. If we have a low hepcidin condition, we increase the iron uptake. However, we're not storing too much iron. We're releasing this iron into circulations. And if we're having a high hepcidin, we do the opposite. Still having a higher iron uptake. However, we store the iron inside the cell. We are not exporting the iron in circulations. So we're having a lot of iron in a ferritin form or storage form inside the cell when we're having a high hepcidin. The relationship between the cancer and hepcidin is that the tumor itself, the macrophage activation, the pro-inflammatory cytokine that coming from tumor, like interleukin 6, all of this affecting the liver, which is the main source of the hepcidin, to increase the hepcidin. This will increase the iron in a storage form inside the cell and decreasing the plasma free label iron. This will cause a function iron deficiency anemia or a cancer-related anemia, which is actually completely different than obsolete iron deficiency anemia because the treatment is different. In obsolete iron deficiency anemia, the treatment is iron or blood transfusion. However, in cancer cell, it's completely different. We don't have a problem with the iron. We have a lot of iron inside the cell. We have a problem with the hepcidin. So if I need to treat the cancer iron deficiency anemia, I need to decrease the inflammatory cytokines. I need to inhibit the tumor itself to decreasing the function iron deficiency anemia. However, from this slide, we know that iron is very important in cancer with a different mechanism. Cancer depends on the iron in signaling pathway and a mutation of P53, which is a tumor suppressor gene, in cell cycle progression, in oxidative stress controlling, in hypoxic induced factor pathway, and also iron is a coenzyme in DNA replication and repair. So cancer cells love iron. They love to have a lot of iron inside it. However, the iron have a dual properties, as we said before. It can facilitate tumor growth, or it can cause a cell death, which is a ferroptosis, cancer cell, due to accumulation of iron and failure of antioxidant defense mechanism of the cancer. So actually, because iron is good and bad at the same time, so cancer cells tend to increase the antioxidant defense mechanism and tend to pack the iron in a ferritin form, not in a free label form. Speaking about the cancer antioxidant defense mechanism, there is multiple of them. However, the most important mechanism in antioxidant system against the ferroptosis is the glutamine cysteine antiport. The glutathione, which is the major antioxidant that the cancer use to resist the chemotherapy and radiotherapy and any octotherapy, including ferroptosis and high dose of vitamin C and hyperbaric, all of this treatment is oxidizing treatment. It increases the oxidation stress inside the tumor. If the tumor able to produce too much glutathione, it will buffer this treatment, it causing resistance. Where the tumors bring the glutathione? The glutathione is coming from cysteine. So cysteine is the building molecule of the glutathione. And the tumor cell can get cysteine from two mechanisms. The first one, which is the most popular one, 80% of the glutathione is made from the cysteine that being imported from extracellularly in exchange with intracellular glutamate. So cancer cell give the glutamate to outside and take the cysteine inside, making the glutathione out of this. Luckily enough, most of the pharmacological treatment using in ferroptosis, including the Cysteine chemotherapy and sulfasalazine from off-label drug, can efficiently block the glutamine cysteine antiport and protect the cancers from being able to produce too much glutathione. However, we have another source of cysteine. Cysteine, as we just say, the precursor of glutathione or the building block of the glutathione. Cysteine can be obtained from the homocysteine, which is an inert metabolite accumulated inside our body and being washed out within the homocysteine cycle or methyl cycle. Also, methionine, which is one of the essential amino acids in diet, can turn into homocysteine and turn it back to cysteine and giving glutathione at the end. And one reason why the cancer cell is addicted to methionine, the amino acids, is the dependent on glutathione because it needs a lot of glutathione. It increases the transsulfuration pathway, so it increases the addiction to methionine. When we're talking about methionine restriction diet, the second subject in these lectures, we'll understand more and more. So there is a lot of research has been done on the ferroptosis to be in the horizon on cancer management. And there is a lot of success with the ferroptosis with the cancer. And to move this success from animal model and cell culture to the human, we need to understand more about the molecular mechanism of the process itself and the pharmacokinetics and pharmacodynamic of the drug that induce this mechanism. Ferroptosis actually can antioxidant failure, especially the glutathione, and induce endoplasmic reticular stress. If we did this together at the same time, we can induce ferroptosis as a cell death. There is some herb and medications and nutraceutical that can actually transport the ferritin from a storage form to free iron. We called it unback ferritin. So it can unback the iron from ferritin to freeable iron to be able to oxidize. Most of this, or the most famous one of this, is artemisinin. Artemisinin is a phytochemical, the active molecules coming from the artemisia, or the worm seaweed, one of the traditional Chinese medicine. It's very effective in driving cell death due to accumulation of iron. And by the way, it's FDA approved in malaria because of the same reason. Artemisinin using with the malaria parasite to unback the iron inside the malaria parasite, increase the oxidation stress inside the malaria and causing its death. In my lab, we did a formulation of artemisinin to be used in cell culture trial, and we used 6 different kinds of cancers: breast cancer, hormonal positive and hormonal negative, hepatic carcinoma, pancreatic carcinoma, glioma, and too many others kind of cancer. And we found that artemisinin was able to reduce the concentration of the cancer cell with even low dose. However, this is only in normoxia conditions or normal oxygen level. In hypoxic conditions, which is usually most of the cancer having the hypoxic conditions, we lack the artemisinin effects, or at least there is a huge difference between the hypoxia and normoxia within using the artemisinin, which is completely logic because artemisinin is not killing directly the cancer. It unbacks the iron, making the iron more liable for oxidation. If you don't have the oxygen, you don't have oxidation. If you have oxygen, you have oxidation. And that's why we can increase one more element in the ferroptosis, free-label iron in presence of oxygen. Sulfasalazine, the other drug that actually can inhibit the glutamine cysteine antiport, which is actually can deprive the tumor from cysteine and glutathione antioxidant system. Unfortunately, it's having a very high dose tolerance curve. As you can see in the bottoms, this is the sulfasalazine. It didn't do any effect to the cancers. With the low dose or medium dose, it did this with a massive high dose, more than 1,000 microliters, which is actually, this dose is very effective to kill the cancer, but also it carry a lot of side effect. That's why we use the nanotechnology in drug delivery system to increase the selectivity and to increase the effectiveness of this drug, sulfasalazine, without actually having any kind of toxicity. And we will know about that in nanoparticle technology. So, long story short, we use multiple phytochemical artemisia from worm seaweed, withaferin from ashwagandha, lactoferrin, one of the milk components. We use EGCG, this all to induce a free label iron. We use EGCG coming from green tea, and nutritional deprivation or fasting can actually having endoplasmic reticular stress effect. Sulfasalazine is the most treatment that being used to cysteine glutamate antiprotein inhibitors, and sometimes we're combining this with homocysteine balance like low methionine diets. If we did that, we can have this result. This is the first patient of mine. It was a palliative case, which was taken only, it was a stage 4 breast cancer, metastasized to everywhere in the body. And she had the huge recurrence in her breast like that. She had a very high ferritin and a very high tumor markers. Ferritin is over 1,000 and tumor marker over 700. When we start the ferroptosis protocols, we notice decrease of the ferritin and also decrease in the tumor markers, and also grossly the tumors become smaller and smaller and more softer. So, as we just said that methionine restriction diet, methionine is the essential amino acid, which means if you can't get the methionine in diet, your body cannot make it. So basically, if I restrict the methionine in diet, you will not be able to provide the methionine or even the methionine metabolic pathway. That's why it's FDA approved in treatment of children with a very high homocysteine level at the congenital lesions. However, the low methionine diet, which is FDA approved in children, is not low glycemic index. It's still containing too much carbohydrates. And carbohydrates, even if I'm not intended to restrict the carbohydrate in diet as an energy source for the tumor, still carbohydrate will increase insulin-like growth factors, obesity, and a lot of inflammation. So we did a small modification in the FDA-approved low methionine diet to be also a low glycemic index carbohydrate intake. Methionine is not important for the tumor only because of cysteine, which is the precursor of glutathione, but it's also very important for the tumor because it's a source for polyamines, important for cell proliferation, and also it's essential in methylation, DNA, and RNA, and protein repair. There's a lot of clinical trials that are being done in restrictions of methionine in cancer patients. The most famous one of them, they use the methionine restriction in clinical phase 2 trials with a breast cancer and glioma, with or without the chemotherapy. They found that 5-fluorouracil, one of the very old chemotherapeutic agents, it's a folate-based drug, chemotherapeutic drug. When we're using alone in a low dose or a moderate dose, it didn't do anything to the tumor. When you combine 5-fluorouracil with methionine restriction diet, it did a great job. No wonder that cancer cell, breast cancer, despite its origin, can cause a hyperhomocysteinemia, and there is elevation risk if you have a high homocysteine or folate deficiency with a carcinogenesis, as being revealed by this meta-analysis. There is also multiple single nucleotide polymorphisms that being very common among most of the cancer cells related to methionine or methionine metabolism pathway like homocysteine removal. That's why in 2019, National Cancer Institute in her magazine, they published this, not as a scientifics, but for public peoples, that's saying that altering diet enhances the response to the cancer. And the diet they mean here, it wasn't the ketogenic diet. It was the methionine restriction diet. They found that methionine is needed for cell repair and also to reduce the oxidative stress and to reduce this methionine having a very good effect. And they mentioned the 5-fluorouracil experiment. Then when we give the 5-fluorouracil, it didn't fail to shrink the tumor. However, in restriction is giving too much effects. Clinical study has been done with the patient of colonic carcinoma preoperative. They giving the patient 5-fluorouracil with 14 days methionine restrictions. And they found a complete regression in most of them, even before surgery, which is a grade 3 response. However, till now, the patient of colonic carcinoma that underwent downgrading by chemotherapy before surgery, there is no any recommendation about taking the methionine restrictions despite these good effects. I will advise you guys to read this book by Robert Hoffman, one of the godfathers methionine science, and you will find a lot of research that being published comparing the chemotherapy, multiple chemotherapy alone or in combination with zero methionine. You can see a great reduction in the tumor cell count, the purple one, when we're using methionine restrictions. Also, we found that methionine restrictions is better than the chemotherapy. Methionine restriction alone was better than chemotherapy alone. The best response was combining all of them together. This is one of my patients that being on methionine restriction diet because she had a renal cell carcinoma. I published this as a poster session in multiple conferences. This patient actually having a renal cell carcinoma, and unfortunately, she have a congenital agenesis of one of the kidneys. So she have only one kidney, and on top of this kidney, she developed renal cell carcinoma. She refused the surgery because she refused to do blood hemodialysis for life. So we put her in methionine restriction and multiple other metabolic treatment because she had a very high homocysteine at that time. And we found a great reduction in the tumors up to a complete necrotic area called photopenia of the tumors on the PET scan after only 3 months. No chemo, no radio. However, methionine restrictions was not only for the tumor cause, but also because low methionine diet is usually a plant-based diet. And a plant-based protein is very friendly with the kidney. An animal-based protein increase the kidney profile. So when we're applying the plant-based methionine restriction diet to this patient, not only the tumor cell improved in response, but also the kidney profile improving too much. Third topic today is the application of light and sound in cancer management. And when I mention light, I mean laser, especially the red laser 660 nanometers, infrared laser 810 nanometers, and blue light, which is 430 nanometers. Ultrasound, I mean the low intensity, ranging from 1 to 3 megahertz focused ultrasound. This is a visible spectrum of the light, and this is the near infrared. Starting from the near infrared to the near ultraviolet A and B, called the photobiomodulations effect. What's meaning by photobiomodulations? Before we saying that, let me differentiate between the laser and the LED, or light emitting diodes. Both of them can do the same work, the same biological actions. However, laser is more coherent light, and also it carry mostly a single wavelength. However, the LED having multiple wavelengths, as you can see, and the power of the laser is much higher than the power of the LED. Both of them doing the job, but using laser is more powerful than using LEDs. We talk about the photobiomodulations coming from photo, which is mean light, bio, the living cell, and modulation is the extra influence on. So the term of photobiomodulation describes the biochemical reaction that occur inside the living cell in response to the light and causing influence on their metabolism. Inside our mitochondria, we have a natural photosensitive substance called chromophore. This chromophore is actually cytochrome C oxidase mechanism. If we irradiate the mitochondria with a red light, 600 to 610 nanometers, and infrared light, which 810 nanometers, we increase the calcium efflux, we increasing the ATP synthesis and reactive oxygen species. If we increase the reactive oxygen species to the mild level, it will act as a signal transduction, increasing the cell progressions. If we increasing to very severe level, it will cause severe oxidative stress and will cause a cell regression and proliferation. So the photobiomodulation carry a dual mode, biphasic mode. It can inhibit or can stimulate the cell growth. With a low dose of laser, with a low influence of lasers exposure, we can have the best stimulation effect to the cell progressions or cell divisions. With a higher dose of the laser, we can reduce the cell progression to the limit that cause a cancer cell death. So if we use the photobiomodulation in sport injury, in wound healing, we will use the photobiostimulatory effect with a very low dose. If we use the red light or infrared light as a photobiomodulation with cancer, we need a huge dose, a very high fluence that cause a cancer cell regressions. And be careful, if you use the red light or infrared light with a low dose, you can increase the cancer cell proliferations. Different than the photodynamic therapy, photobiomodulation having its own natural photosensitive component inside the mitochondria. So you don't need to do anything unless you expose the area that you want to treat to the light. However, the photodynamic therapy, which is very ancient, my grandfather in Egypt, they found this thing in the temples in Egypt, and actually they found that they giving the patient or the peoples some kind of plant, and after ingestion of this plant, they induced under sunlight to treat their sickness, which is the basic idea behind the photodynamic therapy. So photodynamic therapy has been developed since 1800s till now, till it become an FDA approved. And the last FDA approvals of photodynamic therapy in treatment of cancer was in 2022 in prostatic carcinoma. And the first approval was in 2004 in superficial skin cell cancer. So actually, photodynamic therapy, basically I give you a drug called photosensitizers, and then after a period of time, allowing the accumulation of this photosensitizer into the cancer cell, I irradiate the cancer cell with laser. So what's happening here, that the laser is the power source, stimulates the photosensitizer from ground state to excited state, and during this stimulation, it's releasing oxygen atom, single oxygen atom, at the reactive oxygen species generations. So actually, it kills the cancer cell, causing toxicity of the cancer cell by the same way of radiotherapy, but without radiation. Three basic elements. These three basic elements, each one of them is non-toxic. The photosensitizer is not toxic alone, the laser is not toxic alone, and the oxygen, of course, is not toxic alone. However, the combination of these three non-toxic components will cause a cytotoxicity by generation of free radical and cancer cell death. So this is the area of the photodynamic therapy, the combination between photosensitizer, oxygen, and light source. And we need to make sure when we treat patients with a photodynamic therapy not to harm the normal cell. So we need to make sure that only inside the cancer cell this combination occur. We need to make sure that in normal cell, if the oxygen is there, the photosensitizer is not there. And if the photosensitizer and the oxygen there is no light source going there. And I will tell you why in a minute. We have a limitation of photodynamic therapy, and we have a way to solve these limitations. The first limitation is the tissue hypoxia, because no oxygen, no oxidation, just like the artemisinin in ferroptosis, will not have any kind of effect. That's why the patient underwent the photodynamic therapy, usually just before the sessions. They receive ozone, hyperbaric oxygen, or a measures inhibitions labs, we work on a small drug molecules called acrylflavine that's actually approved to be a potent hypoxic inhibitors. So the tissue hypoxia is a limitation, and we can solve this limitation by this way. Limited light penetration. Laser can penetrate only from 2 to 3 centimeters below the skin. Most of the cancer cell is deeply seated. How we can solve that? If we change the energy source, instead of being a light, it will be an ultrasound. We can have an effect called sonodynamic effects. And ultrasound can penetrate more and more up to 12 to 20 centimeters below the skin. Also, we can use the fiber optics to deliver the light just direct inside the tumor. It's called interstitial or intratumoral photodynamic therapy. Sometimes we use intracavity photodynamic therapy just in case of like the urinary bladder carcinoma. We can introduce the light inside the urinary bladder by a fiber optics. The third problem with the photodynamic therapy that we still having a possible damage to normal tissue. That's why we need a targeted nanoparticle technology to enable the photosensitizers to target the cancer cell only with minimal effect on the normal cell. And we need to design this photosensitizer by a way to be accumulated only in cancer cell. So even if the normal cell taking some of them, it remove this or excrete this during the period of accumulations. The amazing molecule, which is the acrylflavine, was examined alone or in combination with a photodynamic therapy. If you see here, this is the violet spot in the cancer. When we did a photodynamic therapy alone, we're having a good response. When you give an acrylflavine alone, still having a very good response, better than photodynamic therapy alone, because it's hypoxic induced factor inhibitor. It inhibits the hypoxia. When we combining both of them together, we have the most effect on the cancer cell. So despite that the photodynamic therapy is being FDA approved, there is no approval for one of the octitherapy or anti-hypoxic therapy to be used with a photodynamic therapy. I don't know why. Sonodynamic therapy, as we just mentioned, we use the focal ultrasound. Focal ultrasound will cause a phenomena called acoustic cavitation. Basically, it forms a cavity. And then this cavity will increase in size. When it takes more ultrasound energy, the bubble or the cavity will increase in size till the limit that the surface tension of the fluids made this bubble become lower than the high energy acquired inside the bubble. It explodes. When it explodes, it releasing a massive amount of energy causing thermal damage or hyperthermia. It emits light in a phenomena called sonoluminescent phenomena, which means a light that can be reduced from a sound. This light can actually stimulate the same photosensitizers and causing the photodynamic effect or sonodynamic effect. Also, the ultrasound shock wave can cause a mechanical damage to the tumor cell itself. The cell death, because of the sonoluminescent, is the same as photodynamic therapy. It's apoptosis, programmable cell death. However, the cell death of the mechanical damage or thermal damage will be necrosis, causing swallowing and some inflammation. That's why we found that treating patients with sonodynamic therapies, a successful treatment can cause what's called pseudo progression, which means it can increase the size of the tumor. However, the metabolic uptake of this tumor in PET scan will be less in metabolism, but higher in size. This is a pseudo progression. It's not a true progression. Sonodynamic therapy, very famous right now for treatment of intracranial glioma, like GBM, and a combination of sonodynamic therapy with photodynamic most long-term cure in brain tumor patients. There is an on-running right now clinical trials in Phoenix about the recurrent high-grade glioma and sonodynamic therapy. And this is actually a thermographic pictures of musculoskeletal sarcoma treated by sonodynamic therapy, and we need to demonstrate the immediate effect of sonodynamic therapy. As you can see in these pictures, the first one on the left is the tumors before treatment. It having a very high vascularity, the red colors. When we treat with an ultrasound, the redness was more and more, and that's because the thermal damage of the tumors. After 10 minutes, it becomes to decrease, and then after 20 minutes, the vasoconstrictions effect cause the tumors to be less viable or less blood circulation going to the tumor. We mentioned the photosensitizer, which is a drug that being excited either by light in photodynamic therapy or by sound in sonodynamic therapy. Multiple of them can be obtained from a natural source, like curcumin carry a photosensitizer effect, like chlorine coming from chlorophyll or chlorophyllin A. Methylene blue itself is a red light photosensitizer, but each one of this can be stimulated by only one laser light. Methylene blue is stimulated by red light. However, curcumin is stimulated by blue light. There is a multiple generation of photosensitizers. The best one is the third generation. As I just say, it's a conjugated liposome that actually accumulates the dye or the photosensitizer only in tumor tissue and target causing the photosensitizer to be targeted to the cell. One more thing we can do is a drug-loaded microbubble. We can make a microbubble on the lab and load this microbubble with any artificial gas like oxygen or bare fluorocarbons, and we can load it even with a drug. Then we inject this microbubble to the patients. So at the site of the tumor, we will put an ultrasound. The ultrasound will cause an impulsion of this bubble, releasing the cargo or the drug or even the gas inside the tumor tissue when it being under the ultrasound. So just like a triggers, we try to target or trigger the drug to be just inside the tumor by using the ultrasound and the microbubble. And there is a lot of chemotherapeutic agent that under clinical trial using a lipid microbubbles to decrease the dose and increase the concentration of the drug inside the tumor cell. We can use a microbubble to increase the effect of photo and of sonodynamic therapy inside the cancer cell. And this microbubble was developed in my lab containing methylene blue, one of the photosensitizers, and filled with oxygen. And we injected to the patients, and then multiple patients underwent the sonodynamic therapy, and we found this phenomenon. This paper is published on the internet. You can find the source. It's called pseudoprogression as an overradiological sign of solid tumor underwent the sonodynamic therapy. And actually, we give the photosensitizers that we developed in our facility, oral and IV microbubbles, and then photodynamic therapy and sonodynamic therapy after oxygenations, either by using ozone or hyperbaric oxygen, or a combination of all of them, including the acreflavine. You can see here in the results, this is a definition of pseudoprogression. It's a metabolic regression despite morphological progressions, which mean the tumor size may increase, however, there is a huge reduction in tumor activity. And this is an immediate effect. After 3 months, it turned to be totally regression or truly regressions. You can see here the tumor in the image in the bottom is smaller before than now. However, now it's much less in activity. And we treat several patients, lung, pelvic, ovarian, and even urinary bladder carcinoma. This is one of my cases. I love this case because she was 12-year-old female. She had a paraplegia diagnosed with dorsal ependymoma. Actually, ependymoma is not a bad tumor. It's not a horrible one. It's carry the malignant features. However, it cannot be treated with chemotherapy or radiotherapy. And the only treatment available is complete surgical resections. You can see on the left image, the tumor is here and here. It's very big. It occludes the spinal cord. It's inside the spinal cord. It was totally impossible to remove the tumor from the spinal cord, so they just take a biopsy from the small tumor parts and they confirm the diagnosis. However, no treatments. She was referred to me by one of my colleagues to see if I have an options for her. We start the photodynamic therapy and sonodynamic therapy. Luckily enough that during surgery, they remove the posterior arch of the bone in the vertebral column, which is actually make a perfect sonic window. So the ultrasound cannot travel through the bone, but now it can travel to the tumor because there is no bone here. And then we introduce a needles here, just we stop over the dura, irradiate the light. And after 8 sessions, we can see a dramatic change in the size of the tumor, even with some edema at a post-therapeutic favorable outcome. The same outcome that's seen on radiations, however, without radiations. The patient was able to walk again because of this maneuver. Grade 3 astrocytoma invading the corpus callosum part is not surgically resected. They can remove the most of the tumor. However, the part that touching the corpus callosum cannot be removed. During the surgery, we did a photodynamic guided resections and an intraoperative photodynamic therapy. And then this is the immediate MRI after the surgery. We removed the most of the tumor. However, in the red circle like now, this is a corpus callosum, and this is a part of the tumor that cannot be removed. After only 8 sessions, which is actually like 2 months of treatment with sonodynamic therapy carry a perfect response in neural cancers, spinal cord or brain.
Doctor, looks like your screen is frozen. You might have to turn your video off. Oh, looks like we lost him. We'll wait for him to log back in. While we're waiting, I'll just say that I tried ferroptosis as well. I tried everything, and I tried this as well last year. And the way I did it is I got the drugs he mentioned, the sulfasalazine or something like that. He also skipped over one slide pretty fast, but a statin was on there. I had that. Is he back? Doctor, are you back?
Yeah, I'm back. I'm sorry, guys.
Yeah, your
Yes.
slides froze there. Okay, go ahead.
Yeah, I'm sorry. Okay, so this is the same slide, the last slide you had from me, right?
I don't think we got to that
No,
one.
go back one or two.
Which one? This one?
That one.
There we go.
Okay. So I was saying that we use the intraoperative photodynamic therapy as a guided resection and as a photodynamic therapy to the part that cannot be resected. Of course, immediately after surgery, we can't judge the effect of the photodynamic therapy. However, this is a baseline we started after tumor resections. And this is after 8 sessions of sonodynamic therapy. After 8 sessions of sonodynamic therapy, through a pair hole that left opened as a sonic window to allow the ultrasound to travel to the tumor bed, we applied the ultrasound for 2 months, and we found complete regression in the tumor. Later on, we learned that the sonodynamic therapy and photodynamic therapy is very sensitive to the neural tissue. So the neural cancers like glioma, astrocytoma, spinal cord tumors is very responded and very sensitive to the photodynamic therapy and sonodynamic therapy. The urinary bladder cancer is a perfect candidate for photodynamic therapy because we can apply a urinary catheter, we can inject the photosensitizers, the ozone and oxygenation inside the urinary bladder cancers, and we can introduce the light through a fiber optic going through the urinary catheters. We did this with a man not fit for surgery or not fit for the chemotherapy. Turning before and after, as you can see, is a complete regression and the removing of the tumor size. PET scan is not the optimum scan to judge or monitor the urinary bladder carcinoma because the dye or the FDG dye itself, it excreted into the urinary cavity. So if you have a low-grade tumor, you cannot differentiate this low-grade tumor from the normal tissue. However, we can see a huge reduction in FDG uptake from before and afters. The last part, the topic, is the nanotechnology. If you can see, I'm trying to connect all parts together, ferroptosis with methionine restrictions, the nanoparticles in a formulation of photosensitizers of the photodynamic therapy. So nanotechnology in drug delivery system is very important because I think this is a mislink in the metabolic management of cancer. It explains and solves the gap that occurred between the bench side and the bedside. We have a lot of drug, a lot of medication, a lot of maneuvers that been success in animal models and cell culture. However, it failed any clinical benefits. It didn't do any clinical benefits. So the transition from the bench side to the bedside, I think this is because of the drug delivery system. We need a deep dive into nutraceutical and pharmaceutical, everything about them, absorption, tissue distribution, minimal effective dose, the mode of action of the drug, the excretions, which is basically the bioavailability, pharmacokinetics, and pharmacodynamics of the drug. So very quick, the bioavailability means when we get any drug, this drug goes to circulation and then distributed to the tissue, metabolized, and excreted. If you study the bioavailability, which is all of this element, you can explain why the curcumin is very effective in cell culture trials. However, it's not effective in clinical trial because the bioavailability of the curcumin very bad. When we applying in animal models, usually it applied by injections. We introduce the drug directly into the blood. When we try in the cell culture trial, we add the drug inside the cell. However, this is not the case in the human being. The human, when we're giving them the curcumin orally, it needs to go to the drug, to the blood, with a good distribution to the tissue, and we need to monitor the metabolism and the excretion of that. This is the metabolism, distribution, and excretion called pharmacokinetics. Another study of the pharmacodynamic, the clinical effect, the mode of action, the dose-responded effect. Do you remember the sulfasalazine in ferroptosis? The dose-responded effect of the sulfasalazine was steady up till 1,000 mic, which is a very huge dose in cell culture. And then we're having a drop in cell count, which is not the case if you give 12 grams of sulfasalazine. By the way, 12 grams is the minimum effective dose in a clinical trial to use sulfasalazine to induce a ferroptotic cell death. 12 grams of sulfasalazine, which is huge dose, 24 capsule or 24 tablets. It's a huge dose. It causes bone marrow separations, causes a terrible side effects. However, when we use a nanotechnology, we reduce the 12 gram to 125 milligram. Huge reductions in the minimal effective dose. How we do that? Basically, nanotechnology is made to be a carrier for the drug, especially for the oral drug. It enhances the physiochemical stability of the drug. If the drug is photosensitive, you can encapsulate the drug with something that's not photosensitive, so it will be more stable. If the drug is thermosensitive, you can encapsulate it with something that protects against the thermal instability. It can protect the drug from the enzymatic degradation in the stomach. enhance the blood resistant time, which means the drug will continue for longer durations. Some of the drug having a very good absorption and bioavailability, like methylene blue. However, it's only stay in circulation for 2 to 4 hours, which means that every 4 hours we need to ingest a dose of methylene blue, which is not practical. However, in liposomal preparation or nanoparticle technology, even the methylene blue is a very good absorption a while without liposome, but we use the liposome to extend the release of methylene blue up to 12 to 24 hours. So you can get only one dose every 12 hours and you maintain the same drug resistant time in the plasma. We can target the drug to target the cancer cell specifically, not any kind of cell, which is perfect in photosensitizers. We can increase the aqueous solubility or the water distribution of the drug, enhance the lymphatic transport, and reduce the drug efflux like methylene blue. All of this will enhance the oral bioavailability and enhance the drug itself. If we apply the pharmacodynamic, pharmacokinetics, and we solve the problem of the drug that being projected as off-label drug like sulfasalazine or nutraceutical like artemisinin, now we can get a result similar to the results that we see in the culture, in the cell culture. A different kind of nanotechnology we use in my lab, starting from the polymeric nanoparticle, we use a polymer like chitosan-based nanoparticle, the inorganic materials like silicon dioxide, the silica-coated nanoparticle, or iron oxide or gold nanoparticle or silver nanoparticle. The lipid base, which is my favorite, liposome and lipid emulsion nanoparticles. Each one of these nanoparticles having advantage and drawback, and according to what I need to do to the drug, which means not every drug is candidate for a nanoparticle technology. Some drugs didn't need to be in a nanoparticle form. So according to what I need to solve in pharmacokinetics and pharmacodynamic, I can choose which kind of nanoparticle technology I used in my clinic or clinical setting. I will give an example with the curcumin. Curcumin is the active ingredient inside the turmeric roots. When they try the active ingredient inside the turmeric root with an injection form, multiple phase of clinical trials up to phase 4 clinical trials. They use the curcumin with a very high dose to achieve a clinical benefits. Curcumin is clinically effective. Curcumin is a potent anti-inflammatory drug. However, the problem is there is a confusion between turmeric and curcumin. Turmeric is the root, and it's only containing 7.5 to 10% of the active ingredient of the curcumin, which means if you ingest 100 grams of turmeric, you only take 10 milligrams at the maximum with the curcumin. Even this curcumin, the 10 milligram, is poor water solubility, so we absorb less than 1% of that. The minimal effective dose in clinical trial is from 500 to 2,000 milligrams per day. Some company add a berberine to the turmeric to increase the bioavailability. It's actually increased the bioavailability, but only by 9%, which is still very low. So don't confuse between the turmeric and curcumin. And to remember, effective clinical dose is 2,000. This has come from 2 grams of turmeric and the 20 grams, of turmeric, and the 20 grams of turmeric came from digestion of 2 kilograms of turmeric roots. So if you need to have the clinical effect of just one dose, you need to ingest 2 kilograms of turmeric root. So just to blind the turmeric root and put it in the capsules, this is nothing. You need the effective dose and you need the bioavailability. That's why adding the berberine, it only increases 9 times higher or 9% to the bioavailability. However, you can increasing more than 100% absorption and distribution if you use a very simple nanoparticle technology, very simple one, like self-liposome, self-despicable liposome, or even a lipid emulsion of curcumin can increase the absorption and the bioavailability of this more than 100%. That's why the liposomal curcumins came to the market. Liposomal curcumins is actually can increase the concentration of the curcumin, the cellular permeability, and we can target the curcumin to target the inflammatory tissue or the cancer tissue to act as a photosensitizer or to act as an anti-inflammatory process. So you can do anything with a nanoparticle technology. It's not only in drug delivery system, but nanoparticle technology actually can be very good in gene target therapy, detection and diagnosis, and even a biomarker mapping. That's why in my lab in 2023, very recently, we formulated a new dye, photosensitizer agent, that actually can give a fluorescent green, beautiful fluorescent color when irradiate with a blue light. So we use blue cut eyeglasses to remove the blue light from the background, and only the fluorescent tissue will be observed when we're using this kind of blue cut glasses. And we formulate this dye by a way to be targeted only the cancer cell. This a high positive charge alkaline nanoparticles with a high selectivity regarding the tumor. And we apply this dye in 4 different kinds of surgical removal of the tumor. 1 in the brain, 2 in head and neck surgery, and 1 in abdominal general surgery. If we apply this dye by injection or even by just spraying on the surgical field, and we irradiate it with a blue light using special equipment to remove all the blue, the fluorescent green is the only tumor. So you can visualize the tumor and remove it. It's called the photodynamic guided resections. You can see here, after we remove the tumors, we found a little bit of activity here and here. So we did a laser ablation or a complete surgical resection of the tumor under your eye. So it's a photo-guided dynamic resections. And we found that this dye have a high selectivity to the tumor by 99.3%, which is actually a very sensitive to the tumor tissue when it directly applied or directly injected inside the tumor. In the head and neck cancer, we inject the dye in the lymph node, deeply seated lymph node, using the ultrasound guided before the operation. And we target only the high fluorescent green color. In brain glioma, we spray the dye over the tumor cavity and we remove all the fluorescent remaining tumors. And this is a tumor after resected. You can see we can also monitor the safety margin of the tumor. It's something related to the frozen biopsy, nitrogen frozen biopsy. However, this is more accurate and more easily to be obtained. So you can having a safety margin, you can observe the safety margin even during the tumor biopsy.
Say, doctor, I want to mention we are at beyond the hour here, and I don't know if you want to stay. I'm happy to stick around, and I think some of our audience would. But if you'd like
this
to,
is my last slide. I finished.
Okay, all right.
I finished. So this is like a small video introducing how we did the nanoparticle starting from the curcumin till the end, but it's basically the same thing I just mentioned. So I finished my slide.
Okay, do you have time to stick around for a couple of questions?
Yeah, of course.
So around ferroptosis, there's a couple of questions, and I kind of had the same question because I actually tried a ferroptosis protocol and I combined it with keto and with hyperbaric oxygen and a bunch of the pharmacology that you mentioned, and I felt terrible. But other than that, I don't know if it worked. Is there a way to gauge whether this is working other than through scanning and imaging?
Yeah. So the biomarker of the ferroptosis itself, it needs to be monitored as a baseline before you apply the ferroptosis protocol and during and after. How you know that the ferroptosis is working or not? We just mentioned something related to the pseudo-progression. Sometimes you're applying a scan and it's saying that the tumor is progressed. However, actually it starts to be die or to kill the tumor cell. To make sure that the ferroptosis is happened, you need to measure specific biomarkers. One marker of this is called the MDA. This marker can be obtained or can be monitored in a urinary sample. Urinary MDA can actually give an idea about the lipid peroxidations, the cell membrane lipid peroxidations. The baseline urinary MDA, if you start the ferroptosis with a good response, the urinary MDA should be at least double or triple the baseline. If not, so you only take the side effect from sulfasalazine without taking any effect. There is no ferroptosis, there is no lipid peroxidation, there is no cell death. You're only taking the drug to do a metabolic pathway. However, this drug is not delivered perfectly to the cell.
Got it. Okay. So I have a question here from Chad. He says, if somebody is following a low methionine and low glycemic diet, what testing should be done to know? And I think maybe you just answered it. You got to look for
The
basic.
homocysteine level actually is a very basic test for a methionine restriction diet. So anybody with a very high homocysteine, you will know that your tumors is methionine addicted, especially if you take a homocysteine lowering drug and the homocysteine is still elevated. This is mean that it's not due to a defect in methyl cycle, but due to high conversion of methionine in diet. So if you have a persistent high homocysteine despite the treatment, like methylfolate or methylcobalamin, you will consider a methionine restriction diet, and the key of success of this diet is to monitor the homocysteine dropped.
Okay. By the way, if people want to ask questions, you can go ahead and use the raise hand feature and you can ask them directly because I'm just reading what's in the chat. Here's one. Do you have any experience or thoughts on photofrin and red laser light to treat esophageal cancer? And related to that, you said something that kind of struck me. You said at low doses, I think you said red light can actually promote tumor growth, and it's only at higher doses that it's actually therapeutic. So those are two questions.
So photobiomodulation, and we just say using red light without photosynthesizer, depending on your mitochondrial chromophore, is called photobiomodulation. If you used with methylene blue as a photosynthesizer, as an example, it will be a photodynamic therapy. So the rule of the dose is not applicable in photodynamic therapy. It's applicable only in photobiomodulations. If you're using red light therapy without photosynthesizer, you need to be very careful on the type of device that you use, on the total dose that being delivered to the tissue, because of this joule, if this energy, the total energy delivered to the tissue is a multiplication of the laser power from the device and the time of treatment. And it can be calculated by joule per cubic centimeter square. Anything below 35 joule per cubic cancer, because it can increase the tumor growth or the cell growth in general. Anything higher than 35 joule is safer to be used. So photobiomodulation, if you write down the search photobiomodulation in cancer, you will see a lot of publications giving you a warning of using a red light therapy in cancer. However, if you change just one word in the research engine and saying high fluence photobiomodulation, you will find a complete different result. High fluence photobiomodulation is a very high energy of light delivered. So high energy of reactive oxygen species that actually causing cytotoxicity effect. But low fluence, low reactive oxygen species that actually act as a signaling molecule to increase the cell cycle progression.
Okay. So there's a question. Have you considered how selenium deficiency affects methionine levels in the liver? Cysteine and glutathione paradoxes. Selenium is crucial for the management of ROS, oxidative phosphorylation, anaerobic glycolysis, along with zinc and genistein.
It's a very essential, yes, but exactly, yes. Selenium is very essential in reducing the glutathione and liver detoxification and buffering the reactive oxygen species. However, if I'm intending to use the ferroptosis protocol, you need to cut off all the exogenous antioxidants. Selenium, coenzyme butane, acetylcysteine, vitamin E, glutathione, of course. All of this is a direct antioxidant. If you're using any oxygen therapy, if you are on high dose vitamin C, if you're taking hyperbaric oxygen therapy as an oxytherapy, if you're applying a ferroptosis or taking a photodynamic therapy or sonodynamic therapy to increase the oxidative stress, if you even receiving a radiotherapy or chemotherapy, part of them effect is oxidative stress. So any part during the active cancer treatment, never ever use a direct antioxidant because you don't know, maybe this direct antioxidant will buffer the oxidation effect that you need to kill the cancer. A lot of patients taking a very high dose vitamin C, but they're taking glutathione with them. So they buffer the antioxidants. They give it the antioxidant to buffer the cytotoxic effect of the high dose of vitamin C. The same at ferroptosis, the same at radiotherapy.
Gotcha.
Okay.
Rob, did you have a follow-up, Rob?
And by the way, there is a scientific publication called Ferroptosis in Health and Disease. This paper actually explaining the difference between the ferroptosis as a bad guy and a pathogen, okay, in neurodegenerative disorders like Alzheimer, dementia, was linked to the ferroptotic cell death to the brain. And when the ferroptosis is a good friend to be used as a cancer cell mechanism of cell death. So actually ferroptosis can be a part of disease or can be a part of the treatment. And they described in this paper the different when to use the antioxidant. I will give you another example. The patient with a high intracranial hemorrhage, if they're having a hemorrhage intracranially, usually the patient died because of the ferroptosis cell death of the brain. In this case, we give a ferroptotic inhibitor. We give a very high dose of glutathione, very high dose of antioxidant. We need to suppress the ferroptosis in neural tissue. It's different when and why we're using the treatment.
Interesting. Yeah,
I've seen.
Yeah, I've seen some slightly different things, but it's interesting how you're looking at it. So, I did have another question. When you're doing nanoparticle technology, you're looking at zinc oxide nanoparticles for treatment.
We already did the zinc oxide nanoparticles. However, we test the zinc oxide nanoparticle from the physiochemical stability of the drug, from the distribution to the cell, and from the nanoparticle parameters like the molecular size, the zeta potential, stuff like that. We didn't start to use this as a cell cultures or a different model. Yes, it's only a lab work, but next in the futures, we will start to applying on animal models.
Good. I think you're going to find great benefit going that direction from the work I've been doing with zinc with patients. It's a very useful tool. So, okay, thanks.
Here's a question. Is the sonodynamic therapy related to histotripsy? I don't even know what that is. I hope that you do. Oh,
I'm sorry. The connection is a bad here in Egypt. I'm sorry. So can you repeat the question again?
Is the sonodynamic therapy related to, I don't know how to pronounce this, histotripsy? Histotripsy, Histotripsy. Does that ring a bell?
Yeah. It's a different thing. There is a difference between the high fluence ultrasound or the high focus intensity ultrasound and low intensity focal ultrasound. The sonodynamic therapy, usually we use the ultrasound with a low frequency, a low power, a low frequencies, just to stimulate the photosynthesis. However, there is another kind of treatment, it's a very new treatment, that they're using the shock wave or high intensity of ultrasound to mechanically disrupt the tumor. It's completely different mechanism of actions.
Okay. Okay, I don't see any other questions in the chat. If there are, and if anybody does have a question, go ahead and use the raise hand feature. Otherwise, we went over a little bit. Okay, Ellen Miller has a question. Go ahead, Ellen.
Yeah, hi. Maybe this might not be the right question at this time since we're at the end here, but I'm wondering, like Roger, I don't know if there's any way to, I know you put in that Word doc, but I wonder if there's any way to sort of translate this for those of us who aren't quite as sciencey as others. Just put that out there. That may not be anything for the doc to have to do, but perhaps there's someone in the lab that could, just putting it out there.
Ellen, I know what you're saying, and I think if you read the Word doc, it's very accessible, and it kind of goes into this because I'm just a layman, so if I can understand it, anybody can, and I think it'll give you a high level. But what I got out of this conversation is that I guess the dose is what makes the medicine. For example, the sulfasalazine, I didn't know you had to have that high a dose to get a response. And I think
You
what
don't
I'm
need to get too high like that. You will have a very toxic side effect. However, the minimal effective dose, when we translate the minimal effective dose from animal model and cell culture we produced to that clinical trial, we found that you need the equivalent of this minimal effective dose is 12 gram. So to see an actions, you need to take a 12 gram, which is 24 capsule of sulfasalazine. We didn't do that, but we did the nanoparticle technology, and we found that the equivalent dose when we turn the sulfasalazine to nanoparticle is from 125 to 250 milligram. When we did that, and when we tried that, we start to see a very good effect, elevation in urinary MDA, which means successful of the ferroptosis, and also a very low side effect.
Yeah. And the other thing well, thank you for that. It's good to know. The other thing that I'm getting out of this is that I think this is much more effective when used in a medical facility with people that are able to measure the biomarkers. You can watch this very carefully and make sure they can toggle it to get the right.
Of course.
Okay. Oh, Raj has a question. Go ahead, Raj.
That was going to be my question. Are there medical facilities or labs which administer the drugs or the treatment for ferroptosis that you can do this under some guidance?
It will be as a research facility because there is no standard of care guideline for the ferroptosis up till now, or for any of this drug or any of this metabolic pathway. So in Egypt, we have before I was a senior researcher in Egyptian foundations for cancer metabolic research. It was a foundation, and we had a clinic at that time. And in this clinic, I was able to apply all of this treatment because I'm a physician and scientist at the same time. However, I can't say that I know any medical facility doing this right now. It's all regarding research.
Good. All right. Seeing no other questions. Assuming there aren't any, if there are any, last chance. Okay, no other hands up. I want to thank you, Dr. Elsakka, for being here. This is really interesting. It's good to know there are alternatives out there. And I guess the last question I have for you is, how do people get a hold of you if they want to find out more?
Yes, of course. It will be my pleasure.
Okay, I guess we'll circulate some information about where you are and who you are, and we could just go to the web, I assume. Okay, well, thanks very much. Thanks everybody for being here. And I will stop the recording.